All right.
You're good to go, Heather.
Thank you very much. I want to welcome everyone to the first Grey County Mental Health and Addictions Task Force meeting. For those of you who don't know me, my name is Heather Morrison. I am the county clerk. I'm going to call the meeting to order. We have all members in attendance with the exception of Councillor Klumpus, who indicated she will be joining us a bit later. Because it's the very first task force meeting of this group, I'd like to do some just around the table quick introductions so that everyone knows who everyone else is. So again, as I said, my name is Heather Morrison and I am the clerk for Grey County. I'm going to go around my virtual horseshoe here and start with Councillor Burley.
Hi, I'm Dwight Burley, County Councillor, Mayor of Georgian Bluffs. Thank
you very much. Councillor Hutchinson.
Hi, good afternoon. I'm Tom Hutchinson. I am County Council and I'm the Deputy Mayor of West Grey.
Thank you. Councillor Carleton.
Thank you. I'm Sue Carleton, County Councillor and Deputy Mayor of Georgian Bluffs.
Thank you. Councillor Mackey.
Good afternoon, everyone. Scott Mackey, Mayor of the Township of Chatsworth and a Grey County Councillor.
Thank you very much. Mr. Dodd.
Hello, everyone. I am Phil Dodd, the Executive Director of Keystone Child, Youth and Family Services.
Thank you. Councillor O'Leary.
Thank you, Madam Chair. Good afternoon, everyone. Brian O'Leary, Deputy Mayor, Owen Sound, Grey County Councillor.
Thank you very much. Director McNabb.
Hey, Kevin McNabb, Grey County Paramedic Services.
Thank you. Director Fady.
Good afternoon. Barb Fady, Grey County Social Services Director.
Thank you. Warden Hicks.
Good afternoon, everyone. I'm Selwyn Hicks. I like to be called Buck, so feel free to call me Buck if you don't know me. And I'm the warden for the County of Grey and Deputy Mayor for the Town of Hamilton.
Thank you. CAO Wingrove.
Good afternoon, everyone. I'm Kim Wingrove, Grey County CAO.
Thank you. Ms. Vauden.
Hi, Naomi Vauden, Director of Mental Health and Addictions at Grey Bruce Health Services.
Thank you. Dr. Era.
Ian Era, Medical Officer of Health for Grey Bruce Health Unit.
Thank you. Ms. Govier.
Hi, I'm Allison Govier. I'm the coordinator of the Community Drug and Alcohol Strategy in Grey and Bruce counties.
Thank you. Councillor Keaveney.
Thank you and good afternoon, everyone. I'm Shirley Keaveney, County Councillor and Deputy Mayor of the Municipality of Meaford.
Thank you. Councillor Klumpus.
Good afternoon, everyone. I'm Barb Klumpus. I'm the Mayor of the Municipality of Meaford and the County Councillor.
Thank you very much. Mr. McFarlane.
Hello, my name is Clark McFarlane. I'm the CEO of the Canadian Mental Health Association, Grey Bruce, Mental Health and Addiction Services.
Thank you. Director Shaw.
Good afternoon, everyone. I am Anne Marie Shaw, Director of Community Services for Grey.
Thank you. Ms. McClay-Winters.
Good afternoon. I'm Sandra McClay-Winters. I'm a standing member of the Peer Advisory Committee.
Thank you very much. Ms. Deputy Clerk.
Hi, everyone. My name is Tara Werder. I'm the Deputy Clerk for Grey County. We receive agendas and minutes and meeting invitations from.
Thank you. And from our Grey County Communications, we have Rob Hatton, who is running the Zoom meeting. Thank you very much, everyone. The first item on the agenda is the election of the chair and the vice chair, who will oversee the meetings from here until the task force is complete. So I'm going to open the floor to nominations for the chair of the Grey County's Mental Health and Addictions Task Force. Councillor Burley.
I nominate Councillor Brian O'Leary as chair.
Thank you. Do I have a seconder? Councillor Carleton, thank you. Hicks.
All right, I think I have my hand up. Do I? Yes, I completely support Councillor O'Leary, but I would also like to nominate Councillor Mackey.
Okay, thank you. Do I have a seconder for Councillor Mackey? Councillor Keaveney, thank you. Are there any other nominations for chair? Seeing none, could I have a motion, please, to close nominations? Councillor Hutchinson, thank you very much. Councillor O'Leary, are you willing to stand for chair?
Yes, I will.
Thank you very much. Councillor Mackey, are you willing to stand for chair?
I appreciate the nomination, but I will withdraw my name. Thank you.
Thank you very much. Councillor O'Leary, you've been acclaimed as chair for the Mental Health and Addiction Task Force. Congratulations.
Thank you.
Bill, now open the floor for nominations for vice chair. Councillor Carlton.
I would nominate Councillor Mackey for vice chair.
Thank you. Do I have a seconder? Councillor Hutchinson. Thank you. Are there any other nominations for vice chair? Could I please have a motion to close nominations? Councillor Burley, thank you. Councillor Mackey, are you willing to stand for vice chair?
Yes, Madam Clerk, I will stand as vice chair.
Thank you very much. Councillor Mackey, you are acclaimed as the vice chair of the Mental Health and Addictions Task Force. Congratulations. And with that, Chair O'Leary, I will pass the meeting over to you.
Thank you, Madam Clerk, and thank you to my nominator, Councillor Burley, and congratulations to Councillor Mackey. And good afternoon, everyone. We'll move right along here to the agenda. Number 3, declaration of interest. Are there any declarations? Seeing none, if one pops up along the way, you can declare at that time. Introductions, I guess we've already done that. We'll move right on to number 5 with our terms of reference and introduce CAO Kim Wingrove. Kim, floor is yours.
Good afternoon, everyone. Included in your package for today's meeting was the terms of reference that was put before County Council at our last meeting and adopted, but certainly we're open to discussion of that terms of reference. This afternoon, you can see here, I'll just go over a few of the key points in it. This task force is responsible for working with levels of government and community stakeholders to identify opportunities for enhanced community supports for mental health and substance use disorders in Grey County. At this point, we've identified 4 objectives for the committee's work to focus on our community members living with mental health and addictions challenges, particularly youth and insecurely housed or unhoused transient neighbors. To bring together government, non-government, health, and community partners to understand and enable the delivery of interdisciplinary care focused on improving health equity through innovative approaches to meet the needs of our most vulnerable community members in a timely, meaningful, and reliable way. To determine appropriate advocacy to various levels of government for increased access to services and reducing barriers to these services. And finally, to make recommendations for or to take immediate action, focused programs that meet people where they are at to provide person-centered health and wraparound care in order to improve health outcomes and health equity of individuals who are experiencing barriers to health and social services in Grey County. The terms of reference goes on to note that while Grey County doesn't have a direct role in the provision of health, mental health, and substance use treatment, the lack of appropriate treatment or support services has a direct impact on both the services that the county is responsible for, things like paramedic services, social housing, social services, and also into each of our individual member communities. So the task force will work with other levels of government to seek out greater access to mental health and substance use disorder services, funding options, and solutions to assist in the development of a local strategy aimed at prioritizing short and long-term solutions for Grey. Now, we've talked about the membership around this table. We have a number of county councillors and the warden and the public stakeholders that have agreed to join us. And we're so thankful to all of you for lending your time, which I know is scarce, and your expertise to this table. We can't be successful without you. So thank you all so very, very much for being willing to step forward and be a part of this discussion. The terms of reference goes on to say each member will exercise the care, diligence, and skill that any reasonable person would exercise to become informed in the area of mental health and addiction support services. If you don't come to the table with already a deep knowledge, take the necessary measures to ensure that anything that we do complies with legislation, and be committed to achieving and maintaining the vision, mission, and values of the county. So joining us today or on this team, in addition to those that were formally introduced, Allison Govier, who I think is well known to everyone, and Darren. Kevin, Darren's not with us today, is he?
He actually ended up calling in. I'm pretty sure he's on now.
Oh, I see. Okay, Darren, you just want to say hi? So if I don't know if Darren's, yeah, there you are. There you are, Darren.
Hi, it's Darren. Nice to meet you all.
Thanks. And Darren has really played an instrumental role in a number of the outreach initiatives that were undertaken as part of the whole COVID response. And I think that'll become clear when we have a chance to hear from the first responder group, of which he is a part. So that's our terms of reference. Did anyone have any questions about the terms of reference for the committee's work? Any suggestions, anything like that? It's really important that we all have a shared understanding. Do I see your hand, Clark?
Yes, thanks. Just one thing, just very minor, but my name is MAC.
Oh, goodness.
McFarland. The other is, I noticed in the terms of reference, there's a theme of improving access to services, and if we can just have access to services, it would go away. I think we may need to be open to looking at some larger structural issues and recognize that although services may be available, it's always the individual's choice as to whether to access. So it is a complex issue with many layers. Certainly the appropriateness of the services, or the configuration of our resources right now is I think a productive topic. But I just wanted to make that point, that I don't want wouldn't want people to walk in with an oversimplified view of, if we can just make things accessible, it'll all go away. There are some big structural issues.
Thank you so much for that, Clark. And I think it's an excellent point that we're coming into this as the county looking to understand from the people who have the subject matter expertise. So you're right that there is a little bit of a flavor of a preconceived, there's just not enough services for everyone. But I think what we're looking for from each one of the subject matter experts is your sense of what both the barriers and challenges, as well as the opportunities, are when it comes to addressing what we see.
And sorry, Dr. Ara, just one supplemental. I was very pleased, if I recall, I did read something about design and healthy communities, and I thought that was wonderful to see in the terms of reference, and very forward thinking of the council, and so important to consider.
So Kim, if I could, I just wanted to share with the rest of the committee. I put a lot of thought into the terms of reference, and I've gone over the 4 of them, and I've come up with my own as a 5th that I wanted to share with committee, and to get a feel and maybe an explanation or question or comment from the rest of the committee. I kind of feel like it's the affordable housing day when we thought we were doing something really bold, adding a full percentage to the levy. But this is what I'd like to see added as a number 5 objective: to lobby the provincial government to create and implement a curriculum in grades 7, 8, and in first year of high school, a mandatory course worth 1 full credit in mental health and addictions education. And the reason I come up with that is, you know, I go over the, like the community drug and alcohol strategy action plan, and everything is like so good that everything that we've come up with, but there's everything is reaction and nothing proactive. And I think of our kids now that are dabbling in drugs and alcohol and cigarettes and have no idea. It's so much worse than when we were kids. They have no idea what they're getting into. And I just think it's time to do something bold. I know it's a big ask, but I think it can be done. You know, when I think of parents, we have so many parents that are dealing with addictions themselves, and alcohol and smoking and drugs. And a lot of these kids are just following in the same old path and not getting the necessary education that they need. And we don't have anything in place to get to these kids before they make those mistakes. And I don't pretend to think that this is going to fix everything, but it's got to get to some of them and maybe help them before they get into making some bad decisions. So let's just open it up and see if anyone has any comments or questions on that or any of the other things listed in the terms of reference, and we'll take it from there. Dr. Eric.
Thank you. Thank you so much for including public health in this very important work. I echo what Clark's comment was about to be open about the multi-layer that affects this issue or multiple issues that we're tackling here. Upstream approaches would definitely include housing, would include many of the other aspects, and definitely education to younger individuals. Even if you want to go into the long-term new families with new babies, the first 3-4 years of their life will shape the trajectory of their health. So for the terms of reference question, if we can include an item where the work can be open to other layers that will be uncovered as we go forward, I would definitely be supportive of that. And I believe Clark's comment would encapsulate that as well.
Thank you for those comments. Madam Clerk, you have to help me out if there's anyone. I don't see any other questions.
Phil Dodd has his hand up there. So.
Yep, go ahead, Phil.
Yeah, similar to Clark, I had just a typo in the minutes. Or in the terms of reference. My name is accurately spelled, but the organization is Keystone Child, Youth and Family Services. So just a little typo there. The second thing, the question I had or query I had was, is the task force time limited in scope? And if so, is that something we should add to the terms of reference? I'm just a question or query around that.
Kim?
I'm looking at the terms of reference. I know as a group, we discussed that this, you know, what was in the staff report, I think, Heather, if I'm not mistaken, that,
Yes.
Go ahead.
I'm sorry, Kim. So this group report, it speaks to a number of monthly meetings up starting today and including June. This task force is limited by the municipal election happening in October. So there is an aggressive timetable laid out in the next report that was completed by Director Fady on a work plan. So this group will be talking about that time frame in the next report coming up on the agenda.
Anything further, Phil? Any other questions, comments? Okay, Madam Clerk, we have we need to pass this then, the terms of reference of the Mental Health and Addictions Task Force be endorsed.
Yes, Mr. Chair. Now, you did put an amendment. I'll send it forward for discussion, whether you want it discussed as included in the terms of reference, or whether you'd like it as part of perhaps the discussion with the work plan. At the next item, I'll leave that to you and the committee members to determine that, but it would be appropriate to have a motion to endorse the terms of reference. And we will make those minor amendments that the members have indicated. That to me is not an amendment. That's something friendly that the clerk staff can look after.
Okay, I'll ask for a mover and a seconder for this, and I'll just leave it up to the mover if you want to add the number 5 that I discussed. Councillor Burley?
I so move, Mr. Chair.
As is, or with the amendment?
I think the amendment is proper, but I'd like to see, I really think it should go on our next reports where I think it should be. I think we could give it better justice there. That's where I'd like to see it go.
Okay, so Councillor Burley has moved that. I need a seconder. Councillor Mackey, and I'll call the question. All in favor? And that is carried. Okay, item number B, mental health and addictions proposed work plan. And Barb, I'll turn that over to you, Director of Social Services.
Great. Thank you, Chair O'Leary. So I am going to jump into the executive summary. So this particular work plan is fairly high level, but it is aggressive, as Kim mentioned earlier. We don't have a lot of time and we have a lot of things we want to achieve. So you'll note that there was a report that I brought forward that Allison and I worked on and was brought to County Council Committee of the Whole on February the 2nd. There were a number of recommendations included in that, and that came forward from last summer's delegation to Council, which included a number of parties that are on this call today. So today you have a draft work plan that proposes topics to be covered with the associated presenters. We can further develop with a discussion about the key questions that we want addressed. And so after we consider the information that's going to be presented, based on those discussions, this task force will develop recommendations that strategize and identify immediate and longer term priorities that can support the development of mental health supports and harm reduction strategies for Grey County residents. This draft plan is looking hopefully to address any barriers and opportunities, as was mentioned earlier. You'll note that we already have a good deal of work behind us. I included the mental health and addictions opportunities that were highlighted from work in the Hanover Owen Sound Task Force. A lot of similarities have been found based on research and the community partners that were joining us for that particular task force. So they've been listed here. A was to continue to refine the newly adopted protocol by paramedic services to track opioid incidents, to establish the baseline and monitor trend analysis. B was to map out existing mental health and addiction services offered throughout Grey Bruce communities and identify service delivery gaps and collaboration opportunities. C was to further explore urban design concepts that prioritizes creating healthy and happy communities. That was mentioned earlier as well. D was to implement the community safety and well-being plan, very connected with this work we're doing today. And E is to explore funding and resource avenues to implement additional pediatric beds at Grey Bruce Health Services. I think that came forward from some work that was done earlier with the task force for Hanover Owen Sound. And then F was to identify resource sharing opportunities to support not-for-profit program, in-program implementation and service delivery. So we think there's some ways and means to be more efficient with what we're doing. And then G, move forward with the calls to action that were in that previous report. And those calls to action came from AMO originally. So they are well established and shared throughout the province. There are opportunities within that document as well in those calls to action for that larger provincial and federal policy context. So perhaps that's where some of your comments, Chair O'Leary, are looking for us to make some changes in that curriculum and advocate on behalf of what we see are where we could make some upstream interventions. You'll see the proposed work plan does outline the meetings that are coming forward and indicates who would be approached with the organizations to bring forward information. We would be talking today, though, about what it is that we want folks to bring forward to us. What questions do we want answered? What is it we're looking for? What are the specific pieces of information that help us to come to those conclusions that we're looking for? So we've got in February, we're having discussions today, and Allison's at the table, as well as our peer support member, Sandra. We have March, we're looking at a mental health addiction support and harm reduction topic. In April, we're looking at the various community social supports, including the Poverty Task Force, United Way, Salvation Army, Y Housing and Employment, and the Community Safety and Wellbeing Planning. In May, we're looking at a lens of first responders, as well as other health lens, such as primary care, the justice sector, youth and adult probation and parole. And then in June, we have our final meeting for supportive housing, recognizing that Maslow's hierarchy of needs, so housing first. We can't change anything in anybody's lives unless we provide them a foundation of safety, which is housing first model. And then there's a list of organizations that are connected with that particular lens as well. So at this time, there are no legal requirements as of yet associated with the work plan, and the financial and resource implications are yet to be determined. They'll be coming forward based on some of the recommendations that this particular task force comes forward with.
Okay, thanks, Barb. Kim, did you want to speak there?
Just to add, so I think already today, we've heard that maybe we need to be reaching out to the school boards, and whether there's a rep from the Blue Water Board or the Catholic Board who would like to come and speak to their perspectives on this and the kind of supports that are available in the school system, or what the curriculum currently includes. Also, for you, Dr. Era, we were hoping at the next meeting that some of the specific people around that are members of our table here, that they could see their way clear to presenting at the next meeting. So Clark, Naomi, and Phil, like if you would have a place on the agenda the next time to actually speak to what your insights are, but also from the health unit. But Dr. Era, I don't know if that gives you enough time. I know it's been a COVID while. And if the health unit would prefer to be included either at the March meeting or at a future meeting.
Yeah, through you, Mr. Chair, we will make time. We'll definitely make time.
Okay, before we get into questions for Barb, can I get a mover for the recommendation? Councillor Klumpus will move. I need a seconder. Councillor Carlton. Okay, questions for Barb? Comments? We should have this meeting in the morning.
I see Councillor Mackey's hand, Mr. Chair.
Okay, Councillor Mackey, go ahead.
Thanks, Mr. Chair, and good afternoon, everyone. Just before I raise my question, I would just like to sincerely thank Clark, Phil, Naomi, and Sandra for participating, and as well as Allison for providing their expertise for us as we, work through this important role. A question I have, I guess it stems from the county's commitment that we provide to our hospitals right now. I think it's what 0.75% of our annual $400 and some thousand, I think, that we earmark towards capital costs for hospitals, for MRIs, that sort of thing. So I have a question for I guess Phil, Clark, and Naomi in regards to capital and whether or not mental health requires capital costs. When you look at the overall funding that the province provides to mental health, it's about 7%, and 10%, I believe, is the total burden of disease that mental health creates. So there's certainly an underfunding when it comes to mental health. A stat that I read is that mental health is underfunded by $1.5 billion. So I guess I'm just wondering, what role does the county have? When we do already spend money on hospitals, what role does the county have in maybe entertaining requests from mental health associations? Thanks.
I can jump in there. The county does flow money to us already, and we have a number of positions in housing that are funded through the county, which we are very appreciative of, and are always pleased to partner with the county. The funding issue is a really significant one for the sector. We've been underfunded for some time. We survived through vacancy management. Currently, we are waiting with bated breath on a base budget enhancement of at least 1%. I can get you the figures at the provincial level. We've done some work, and we can get you some figures on that underfunding and what it's cost. I think we've fallen, the percentage we've fallen behind over the years. But it is the longer it goes, the more it eats into our capacity and the number of positions we can maintain and fill. So when I heard about the task force and was speaking with Kim, what really gave me hope was to have another advocate to go to government to address that issue and to bring things up. In the coming months and possibly years, I think we can only expect an increased pressure coming out of COVID for mental health, and so it is sorely needed. On that capital side, I don't want to speak for Naomi, but certainly beds, I think we need to have sufficient number, but also I think in sort of tangentially that housing issue comes up with regard to capital. It's challenging. We have to work with landlords. We can't build ourselves. We're dependent on the market for that. But it does take capital dollars to build that infrastructure. And this ties back to the design piece, to make it healthy housing, not ghettoized housing, not housing that none of us would want to live in. It needs to be housing that actually uplifts people and provides them with some dignity too. So.
And I'll just add, oh, sorry.
No, go ahead.
Oh, in terms of beds, you had already mentioned the pediatric beds. We continue to try to operate 2 beds on our women and child unit for our pediatric patients that often wait in the emerge. And that is still no sign of funding for those 2 beds. And ideally you would want to pull out, as Clark said, just having a really healthy environment is so important, especially for children. I think we've done a relatively good job of sectioning off a bit of the women and child unit, but ideally you would really want to have a pediatric mental health unit. We're far from London, and transfers are very difficult. So you've heard from Hanover and South Bruce Grey, I understand, and it's an ongoing issue. Also, in terms of capital, you admit we are not high users of capital historically. I mean, we're very staff focused. When I look at the hospital budgets, as you mentioned, the MRI and these big pieces of machinery, generally mental health, I don't think gets a lot of the capital dollars because it's very, there's such high demands around equipment in other areas of the hospital. And mental health really needs operating dollars. We need staff. We need housing. We can't discharge patients from the inpatient unit without housing. We need a healthy place. We need. I wanted to just, in terms of I think an easy fix is what we know from the Lynn capacity planning report that was done a few years ago is we need more 24/7 clinics. Well, we have none, but people in crisis need help when they need help. And so that ends up being the emerge, which is not the place that we want our patients to go to. So as a part of the partnerships that we've developed, the SOS van with Kevin is an amazing project at putting people, it doesn't require capital, but it's about access. but also having the How Clinic in downtown Owen Sound. If we can replicate that in a number of our communities, it's just really good to have people be able to have access to services even if we partner with other community agencies to staff it, to have a person to talk to is so important when you need that person.
Naomi, maybe for the next meeting, but is there anything to report on where we are with the Old Babies School?
Not really. We are, we've heard this before, but we are understanding there should be an announcement in the next, this week probably. The models was cut significantly due to requests from the ministry, but I still think we can make a great program. So we're just still waiting on that final approval.
Okay, thank you. Just getting back to Phil, I just wanted to, before I forget, when you talked about bringing back information at the next meeting, you talked about your 1%. I'd like to see dollar figures too, just so that we can see a dollar value if that's okay when you bring that back. Phil, did you have anything to add on funding?
Yeah, I would just say in response to Councillor Mackey's question that capital funding is a crucial piece in the work that we all try to do in our community-based sector. And Keystone is the Children's Mental Health Center for Grey and Bruce, and we have only recently been embedded into the Ministry of Health funding envelope. Prior to that, we were with Ministry of Children and Youth Services, and the opportunities for capital funding under that smaller ministry were very low. And I would just venture to say, and I don't want to create any issues here politically, but I'm not sure the Ministry of Health knows that we're under their umbrella yet in terms of capital opportunities. But and early in COVID, the capital, the windows to ask for capital funding had closed or were suspended. And I have not gone back in recently to see if they have opportunities for us to apply for capital funding again now. But it has always been a forever challenge, and one after multiple requests, we've never received any capital funding requests from government in the work that we have been able to do. So it's a challenge for sure.
Always funding. It's always funding. And we keep adding more and more work to it. Okay, any other questions or comments?
Warden Hicks.
Go ahead, Mr. Warden. You're on mute.
Mute, Mr. Warden.
There we go. I thought I clicked the right button. My apologies. And thank you, Mr. Chair. I just want to echo the comments made by Councillor Mackey and just share how excited I am to see the first meeting of this task force. I'm really excited by the amount of talent that I see on my screen here, and excited about the possibilities with this talented group putting our heads together. I'm hopeful that one of the things that we'll be able to do is to make a business case for mental health, for investment in mental health. I think it's there, but I would love to see us have it in a really saleable, presentable, consumable format that we can put out and make that case, not just for government or potential funders, but frankly for the community in general, that mental health, and I think it's gaining its much needed traction, but I would love to see this group, and we're already starting to get into it a little bit, but make that business case about why investment in mental health makes sense. So that's one of the things I'm hopeful for. The other is, and I've been saying this all along, I'm hoping that we can identify some low-hanging fruit, some things that just need a little bit of a push to get it over the edge. A lot of great work has happened already. What are those things, those 2 or 3 things that just needs that little bit extra now to get it rolling? I'd love to see us identify those things just to sort of get some successes and feel a sense of pride that we're, getting the ball rolling on some tangible things. But I'll leave it there. Those are my comments for now.
Thanks, Buck. Actually, you bring up a good point. I think Dr. Aaron and I had a discussion maybe a year ago about doing something like this. And we talked about how the timing just wasn't right. So Dr. I should just mention, or just have you speak on that. You think the timing is, obviously hopefully we're coming to the end of the pandemic. You think the timing is right for this?
Yeah, thank you, Mr. Chair. I do believe the time is right. We are on the tail end of the pandemic, and we have the momentum of working with the community, with different partners, and capitalizing on this and keeping that momentum and rolling it towards this type of emergency that's more I believe, more costly to our society and has been there for years, not just the past 2 years. And if I may, able to share my screen, I just want to use this model for a minute. And if I have the group's blessing, I can build presentation and data around it as well. Sure. If I have the permission to share it.
Go ahead, please.
Thank you. So this is Ottawa Charter. It is a model that was created around 30 years ago and was a game changer at the time, and still been in effect in any time we tackle a complex issue, an issue with multiple variables, and this would be very consistent with the issue we have. There are 5 main approaches, and there are ones that are low-hanging fruit. To echo what the warden mentioned, orienting the healthcare services. That's the first one there, and there's no sequence in them, but it is definitely for people who already fell off the wagon and need support. We need to support that group. A creative, supportive environment. We can give the right prescription and treatment to the person, but if they don't have housing, if they don't have transportation, they're not going to follow anything of that prescription or that treatment. Develop personal skills, and that goes hand in hand with strengthening community action. And all these 4 approaches are under building healthy public policy. And having the county lead this is the most appropriate. We know that the municipal level policy changes are way faster than the provincial or the federal. And if we have a model that works, that could be replicated somewhere else, we're not only finding a solution for Grey Bruce residents or Grey residents, we are finding it for many other people. And public health usually has this circle here, enable, mediate, and advocate. Advocacy level for all these interventions. Again, and this has been in the practice for 30 years, this is not new, and it really allows us to cover all the aspects that we need to cover. And if the group identifies low-hanging fruit in some, or especially in the health services, this is something we can focus on in the coming few meetings, and at the same time not lose sight of the bigger picture.
Great, well, thank you for that. I don't know if that's going to spark some other questions.
I just jump in. I had my hand up there, but yeah, to that same point, I think along those same lines, I think we could maybe consider the recommendations falling on a matrix, because there are the formal services or interventions, but then there are the less traditional. And what comes to mind for me again is that planning piece at the municipal level. Everybody, all the municipalities have that master plan, and there's some really interesting work being done around. I think they're called design interventions, really, which are physically structuring your community to make it a mentally healthier place for people. So there's all levels can do that. And there was I'll try to find the clip. It was on CBC, but there's a fellow, he's a Canadian doing his PhD over in the UK, who's doing it on that as well. He's an occupational therapist by training, but focusing in on that. So yeah, I think again, going back to that complexity, there are many levels and many interventions that we'll need to work on. So thinking of the immediate term, long term, medium term and long term at various levels of intervention, whether it be the healthcare or the municipal, et cetera. I think it falls nicely into a matrix approach.
Great, thank you, Clark. Any other questions, comments? Councillor Mackey.
Thanks, Mr. Chair. Naomi mentioned about the number of people that show up at our emerge departments, and Clark spoke about the lack of proper housing. I'm just wondering about what step down mechanisms are in place right now when someone shows up at the emerge department. What is the step down as far as supportive housing that is involved in Grey County right now? The criminal justice system historically has been the default housing for a lot of people with mental health issues, and I'm just wondering, how do we explore other opportunities and avenues for proper housing as opposed to the criminal justice system?
Mm-hmm. Yeah, so we generally, any patient that comes in, mental health and addiction patient who is in housing crisis, would see the crisis team, and that would be in the rural sites. It would be the CMHA MHeart team, and at Grey Bruce Health Services here in Owen Sound, it would be our team, and then it would often we would then admit someone to our inpatient units or to our withdrawal management services if that was the case. We do really try hard not to discharge to the street, so we would contact Safe and Sound. Our crisis team would contact Safe and Sound and Y Housing and would try to find them housing. However, there are some people on the list that cannot get housing, and I think our community, our partnerships have been very creative, but it sometimes has meant buying tents and sleeping bags and that kind of support. There's very little options for some of the patients coming out of the emerge department.
So Naomi, you only admit if the patient is willing to help themselves, correct? If they have no intentions, they're
No, we admit if we think there's any risk to themselves, if we feel that they're unable to care for themselves at that moment, even if like there's a lot of patients, to be honest, who, let's say they continue to use, but maybe there's some psychosis involved. We would feel that they are, even if we think it might be, I'm going to just use an example, maybe it's crystal meth that is causing the psychosis, we would still admit because we would feel that it's possible that the person is not in a clear enough state of mind to keep themselves safe, especially at this time of year in the cold.
I think as well, when we talk about housing, we have to speak about the supports. It's not simply enough to provide the housing without supports, especially with individuals that need to learn how to maintain a tenancy and will need supports in that. What we have been noticing through COVID as well is that, and I think there's a general trend, and I'm sure Anne-Marie has probably seen it as well, is that the behaviors are becoming all that more severe, that damage is happening more often, that it is harder and harder to maintain the housing for people because there is a tolerance that landlords have, and fair enough, they're doing property damage as well. So it is becoming a much more challenging issue, and I think a need for more supports in that area or intervention somehow to some of these very, very challenging cases.
Absolutely. We just have patients cycling back into the emerge, into short-term housing without supports. They just continue to cycle through, and they're not able to be successful in an apartment without a fair bit of support.
So can I just follow up, Mr. Chair? Maybe through you to Clark, what would a step down unit from the hospital look like, a supportive step down unit in your mind?
Well, I think one thing we would have to have is capacity to receive people quickly. So there's a respecting that the pressures on the hospital is to maintain a flow, and they may be discharging. So there needs to be something that could be accessed quickly, and that would provide that individual some amount of support and stability. So a staffed unit that, whether it be a number of rooms in a house that's staffed 24/7 that people could land in, because that's not just from the hospital, that's also from the jail. People come to the courthouse and they say, well, you're free. And they say, well, great, but my stuff's still back at Penetangwisheen or whatever. So all those scenarios need rapid, just a quick bed, and a short term. And then a linkage, access to the supports and to find the more long-term housing. So I think that's an initial step. And we don't really have that here quite yet.
So Clark, is that healthy to put someone into I guess if they have nowhere else to go, but if you put them into a house where other people are struggling, is that a recipe for disaster? Or I'm just asking. So
it's a very good point. It is a risk that we would have to manage. We're assuming that if they're coming out of the hospital, for example, that they have been stabilized and that they're ready to re-enter. I think it also speaks to the staffing for that unit. So I think it would need to be fairly experienced staff. You couldn't have a single staff on at one time. You'd need to have a couple of staff on, and there'd have to be all those safety precautions, because you never know what mix you might get. And there has to be some contracting, I think, that goes along with that, so that just because they might be booted out if they can't abide by the rules or behave in a certain way, they may end up getting ejected too.
But I just would like to add that then they need to be allowed to readmit. I think.
Oh, absolutely.
Yeah.
Always a low barrier approach, by which we mean, here are the rules, and as long as you're willing to play by those rules, you're welcome. But if you're not, then you'll have to go. But you're always welcome back, so long as you're ready to play by the rules. So we always take that low barrier approach.
So sad. Buck, did you have a question there? Go ahead.
Yes, thank you, Mr. Chairman. And Clark, I really appreciate the comments that you're making around housing. The one point that you made that resonates probably the most with me is no ghettos. From someone who grew up in a ghetto, trust me, I'm all with you on that one. I think people are entitled to love, and people are entitled to dignity. And that's what it's all about. You wouldn't create a place that you wouldn't want to live in and expect other people to live there. So it's about decency and it's about dignity, I think. What I'm learning as I hear more and more of these presentations and participate in discussions, and Anne-Marie will know what I'm about to talk about, which is a range of housing that's necessary. And I had that aha moment when Barb at one point talked about a distinction between housing with supports and supported housing. It was like, oh my gosh, yeah, there is a difference there. So we do need a range of housing. And I'm hearing Clark, you point that out very well. Different people are in different places and have different needs. And also, I'm sure that you have to consider the dynamics of who is currently, even though this might be what you need, the dynamics of the people that are in there right now aren't really ideal for your entrance to it right at this time, I'm sure.
Yeah,
go ahead, Clark.
Well, I just think, there are some options. Like we have a range of housing options, and one is residential, where it's congregate living. And often we have fairly, long-term residents there who would probably be ready to graduate into an apartment, but probably not alone, because they don't necessarily want to go into social isolation. The residential setting provides a community and setting as well, and all the positives that go with that. But if we could access some, 2-3 bedroom apartments, there may be opportunity to graduate a number of people who, get along in that residential setting on and provide some flow for us in our residentials as well. So different ways of approaching too.
Also, when I think of some of the homeless that are in our areas, they are people that really do struggle to be around other people. And that's where, the idea of a tiny house, and again, you don't want a ghettoized group of them, but I think that some of the other areas have done really well with little tiny house communities, because some people really do better with having their own housing without having to share their space.
Okay, Scott?
Yeah, I guess thanks, Mr. Chair. When we're talking about, step down from the hospital, I believe Mr. Dodd mentioned the residential program and as a step down from the hospital. So there's something similar to that? Could it be replicated for the adult system?
I think
that question, first of all, maybe a confirmation from Phil, and if that is actually the case, could it be replicated? Thanks.
Yeah, I would say, Mr. Mackey, that we have acted in that capacity over the years as a step down unit to the children who are finding themselves in the hospital, who come into our live-in treatment program. And it, as Clark identified, it can be a mixed bag of tricks in terms of the fit and the appropriateness. And we've certainly experienced all those challenges with a 7-bed unit. Bringing 7 teenagers together can sometimes be very interesting. And I know in your previous life, Mr. Mackey, you've also experienced that with adolescents in the work you do as well. So it can be a challenge, but I think when the opportunity is there, it's a quick process of a short-term crisis stabilization, assessment, treatment, and transition on. And again, some of the key points made were having that ability to step up and step down. So having that the availability to go back to the hospital if things turn into more of a crisis scenario, and have that two-way interaction is so critical in working with some of this population, both child, youth, and adult.
Anything to add there, Clark?
No, I agree. I think it is possible to replicate that for the adult. It's a question of the bricks and mortar and the staffing and the arranging of it. So the one thing with, I guess, that with the adults, there's always that opt-in or opt-out. So you can't be quite as directive with the adults as you can with the kids, and so there's always that choice element too. So.
I'd just clarify on that, Clark, that our admissions to our live-in treatment program are absolutely voluntary. It's a 3-way partnership, with the young person being one partner, the parents being the second partner, and Keystone being the third partner. Mm-hmm. If anyone says no in that partnership, then Keystone always votes with whoever says no. Yeah, it would not happen as an admission.
In talking about this and designing it, it's so important to speak to those the actual users of the end user of the service and what would work, and because there is that partnering, and we all bring our own perspectives, filters, values to the table, and think what should work. But it's always, I think, good to engage in a fairly robust way with the end user to find out would this work for you.
Clark, is there many success stories, people coming out the other side and actually making it through and straightening out their life?
Yeah, I can introduce you to some. It takes a long time. and it takes quite a range of supports. I think we have to stop thinking about people as our clients, but we as their providers, because they have quite a range of providers and supports in the community. But I think of one young man who came pretty much off the streets with a significant substance use issue and behavior issues, and now has completed school and is employed. He's worked through our social enterprise programs as well, and is doing incredibly well. Is a real success story. So I think we can't underestimate the role of trauma, and so it's going back to that design piece. What does a trauma-informed community look like? What, in terms of the physical structure, in terms of the service orientation, in terms of how we engage people, in terms of the public policy, what does that look like? Because when we're talking about mental health and addictions, we are talking about trauma too. So definitely it is possible. But it isn't quick. It's not a quick fix.
Well, I just wanted to throw that out there because it's good to remind ourselves that it's not all doom and gloom. And I'm sure Phil can tell some successful stories too. And it's good to know that there is light at the end of the tunnel, and some of the things that we are doing are working. And I think that's important to talk about too.
And Kevin, I know you've had your hand up. I'm just going to jump in this one last time. There was a psychiatrist up north when I was up there, and often people would see a readmission to hospital as a failure, and he would often reframe it as it's just a learning experience. And so, we have to expect. Every one of us around this table, has stumbled by times, I'm sure, and it's just part of being human. And we shouldn't see it as necessarily a failure, but as a learning opportunity, and they will go through that process. We all do.
Right, Kevin, did you want to jump in there?
Yeah, I just had a couple of things. Just again, it's not really my expertise, but just some experience we have is. Like we find really with the short-term accommodation late at night or in the evening or weekends or when it happens is getting access even for a place for people to stay, and having the ability of our own place that could be well supported like a shelter. The other thing is to consider is even for people that that may choose to be on the street, is appropriate place for them to warm 7 days a week. We don't even have access to that or go to the washroom. So those are kind of things that I think they're important to come to the table too when we really want to meet people where they're at. That those are some choices that they may make, but there's things that we could do to support them, to help them, and maybe connect with them around that.
Yeah, and I think I've talked to Kim before about the living space model that I was involved with in Timmins, where it was a shelter built on an old motel, where the shelter is on the bottom floor and services were on the main floor, and then we had rooms on the top floor that people could live in as sort of a rooming house, and then get connected to a housing worker and go. But I think that's a really valuable. There are all types of permutations of that model, but it allows for people to come in contact with the service and to build the trust, because there's a lot of trust that needs to be built in order for things to work. So.
Okay, so great discussion. I just want to reiterate that it's so important to have people like Naomi and Phil and Clark and Allison on this committee. I think we've got a lot of work to do, but I think it's we'll get something done for sure. So looking forward to moving along with this committee. So there's no other questions or comments. We have a recommendation. Sue? Sorry, did someone?
Councillor
Yeah, I think you've got, yeah, go ahead, Heather.
So, Mr. Chair, you have Councillor Carlton, and then you have Allison Gobier.
Okay. Councillor Carlton, go ahead.
Okay. Thank you very much, Mr. Chair. Something you kind of alluded to at the very beginning about the education component. It strikes me we're looking at a two-pronged issue here. the main one that we're dealing with is people who already have the mental health and addictions issues, and what can we do to support them? But is there a step back or in a different direction that provides the education early enough so that people learn to recognize when I'm having a bad day, I'm having some issues? I relate it to somebody breaks an arm, they know to go to the hospital and get that fixed. But years ago, my mother-in-law actually had a nervous breakdown and was advised to stay in the hospital for 6 weeks, and the family refused to allow her to stay. Said there was nothing wrong with her. So they didn't allow her the time to recover. And is that what we need to educate people for as well? That it's okay to have these issues and find ways to deal with them. Do we need to give them coping skills way back ahead of getting to the point that they've used addiction as a coping skill for mental health? Just a thought. To me, I see all of this as being kind of two separate issues, but maybe we can approach both of them. Thank you.
I think one of the items that you mentioned there really links to stigma. This person families not supporting them to get help. So I think the more we can do to promote mental health in all of our programs is really important in decreasing the stigma, and that people will reach out. I also will flag that the Ontario Centre for Excellence in Mental Health and Addictions has started to roll out their plan to provide structured psychotherapy to all kind of the more mild to moderate mentally ill, and bounce back's already going on. So they are trying to expand services in that area, and that will be coming to Grey Bruce probably in the fall as well.
Yeah, and it's that stigma piece is huge, and part of it is normalizing mental health issues. There's a fellow in Vancouver who does, he's a comedian, and he has a program called Stand Up for Mental Health, and he teaches people how to use their own story as humor, and it's really quite effective. It's interesting, but his dream is that one day it'll be quite normal for people to come into work and saying, I'm not having the greatest day. The voices are a little loud today. So it sounds a little jarring now, but that's it's kind of where we need to get to, because nobody thinks twice about going to the hospital for a physical ailment, but there's a whole lot of judgment and shame around mental illness and addiction. So.
Anything further, Sue?
No, I don't think so. I think it really is a stigma. And I think if we could help people understand that it's okay to feel that way, and there's resources available to help to get through that. There's ways to get through it before it gets to the point of using drugs or alcohol or something else as the coping skill. So I'd just like to see more of that. Thank you.
Thanks, Sue. Allison.
Thank you. I have two comments. One is a direct follow-up from this conversation. It's just around the education piece. I just wanted to put a plug in for looking at more of the family and structural and societal factors that might influence someone's mental health, or whether or not they develop the substance use disorder, and that the public health unit can likely give us some education about early childhood or adverse childhood experiences, and really how to build those protective factors around the children and the family, so that substance use, there's less risk of substance use. Really looking at the early childhood experiences of neglect, trauma, and abuse. And when you are exposed to that as a child, your the probability of you developing a mental health or a substance use disorder increases as well. So I think there are a lot of environmental and structural factors that also come into play in addition to the education piece. So taking it from looking at from an individual choice lens to a more of a structural and societal lens. That was my first comment. My second is related to the work plan. So I can go ahead and ask that question, or if anyone else has comments on what I've just said about the childhood experiences, feel free to jump in.
Well, I'll speak to that because I hadn't even thought of that. And, you know, for a lot of this is new to me too. But, you know, when I talk about educating kids in grade 7 and 8 and 9, when they're getting into it, you know, what you just mentioned, it's almost too late at grade 7 for the kids that are growing up in whatever that is that me and so many other people just aren't familiar with. So I'm glad you brought that up.
The drug strategy in Peel region developed a framework around substance use prevention that integrates adverse childhood experience as a preventative model. It's something that I can look further into with my colleagues at Public Health and bring back to the committee if that's of interest.
That'd be great.
If I may chime in.
Go ahead.
Definitely early childhood prevention is key. By age 5, it's too late. Kids learn to socialize by age 3 and 4, and if the parents are very successful, that's the time where they would give the child an opportunity to socialize with their peers, and kids will socialize themselves into a healthy relationship down the road. And there are 30% in general of the population that would have a certain type of personality that's not agreeable, where if they receive the appropriate socialization and parenthood or school experience, and they can overcome that tendency not to be agreeable. And if they have not received that, you would see how they were not able to build relationship with their peers, and usually go into activities that would lead to either mental health or addiction, or usually both. So definitely that's not a settled point. And the strategies we have, all of them include not only early childhood, but during pregnancy to ensure we support especially single parents, families, into ensuring their kids have the opportunity to have protection down the road.
So many moving parts. Okay, Allison, did you have anything else you wanted to speak on?
My question is around the proposed work plan. I see under January, the drug and alcohol strategy is listed as a discussion point around a peer support member. Is that something that we'll get to sort of after? Is that an item that we'll talk about later in this meeting? Or is that to be discussed as we're looking at the work plan?
Barb?
Thank you, Mr. Chair. That was added to the report prior to having determined who the peer advisory committee member would be. But I do want to have a discussion about how and what we are looking for from the peer advisory, the member here, as well as the liaise back to the committee. Allison and I have had some conversation about that. And we know how important, I've heard it here in this discussion already, we don't want to build anything without consultation, without inclusion. The experts are those that have lived experience. And I think the other piece that I'm hearing that I'm going to be so interested and I know I want to emphasize is the fact that as if we even have capital dollars, we need to also then look at what are the policies that surround that. What are Are we looking at abstinence policies? We know that doesn't work. We know that even as we look at, where we want to go with some of the advocacy for addictions and supports, if we're really truly looking at supports, we need to look at best practice. We need to look at what is working. And I think we do need to hear from both Allison with the experience at the drug strategy, but also from persons with lived experience to know how the influence of what we think is as the bureaucracy, if you will, and how we're laying out the foundation needs to be really tempered with what's actually being, what will work on the ground and what will be successful with people who are in need of this change in our community. So to go back to the actual question from Allison, the comment was that as we put it in the document today, it was just to ensure that we understood why we had peer advisory at the table, and how maybe to even hear from the peer support person themselves as to what some of the things they think. Sandra's here today. If it's possible to hear from Sandra as to what she's thinking about going forward, and whether or not there are some early insights that you may have that can help us to streamline the work that we're doing.
Thanks, Barb. I'll hand it over to Sandra. And just before I forget, Sandra, I know you and I talked on the phone about, how we want to present this back to the peer advisory committee. There's 11 other members with lived experience who meet monthly, who have been informed about this task force and are willing and open to having some to and fro. And Sandra has been nominated as the person to be that liaison and to also, share from her own experience. So I guess before the end of the meeting, we would sort of like to establish sort of what are the parameters and expectations that we're looking for from this group. And if it's something that, we'll figure out as we go, that's okay too. But I just wanted to put it out on the table. So go ahead, Sandra.
Thanks, Allison. As some of you will realize, I am a Grey County employee, having shared my time in social services and paramedic services. However, on this task force, I will be bringing a grassroots approach from our peer advisory committee. As I have supported a family member through addictions and mental health crisis and recovery, and have been involved with several agencies and services on behalf and with the family member. So that being said, I will be also bringing back feedback, ideas, and issues that are presented by our peer advisory committee when I provide a synopsis back to them with regards to each meeting that I am attending on this task force. Perhaps simply said, I will play devil's advocate for some of the suggestions or policies or thoughts going forward from this task force, and that being in me saying devil's advocate, just from a grassroots approach, how it may be observed or felt from somebody accessing the service.
Okay, thanks, Sandra. Madam Clerk, do we have any other questions? Any more hands up?
No, we don't, sir.
Okay, I think we'll wrap it up then. We've got a motion on the floor moved by...
Sorry, Mr. Chair, if I could just interrupt, the warden does have a comment.
Mr. Warden, go ahead.
My apologies, Mr. Chair. I just threw my hand up last second. If I could, I'd like to go back to Allison's comment around childhood. And I learned through meetings that the whole issue of unaddressed childhood trauma is key around the symptoms, I guess, that we see around adults with mental health and addiction issues. So if that's the case, then I would love to know what are the things that we need to do around addressing childhood trauma. Is it early identification of, pregnancies, or we know that a child, may be at risk? Is it more funding for children's mental health and counseling? I don't know. I'm not an expert in the field at all, but it strikes me that, Allison, you're raising a really important issue, which is that we need to go upstream and thinking about prevention and early intervention. But I don't know what the answers are.
Allison?
Thank you for circling back, Buck. I don't think I would do the topic justice if I tried to answer the question fully right now. I see Dr. Era has his hand up, so I'm going to defer to Dr. Era, but it's certainly something that I agree should be discussed more fulsomely, potentially in future task force meetings.
Sorry, Dr. Ara, I just wanted to jump in. I'm afraid I have to sign off. Have an OHT meeting to attend and share, but really thank you for the invitation to join and looking forward to working with the task force.
Thank you, Clark. Appreciate it. Dr. Ara, go ahead.
Thank you, Mr. Chair. Thank you, Allison, for referring the question. There are different junctures in the span of any person's life where certain events can lead them to experience mental illness or addiction or both. And there is definitely solid evidence in the first early childhood development that prevention can happen at that early stage. What the system offers is Healthy Baby, Healthy Children is one of the programs that we have in the health unit where we connect with families at risk, and there are different mechanisms. Some of them are passive, which is more robust, whether it's referral from the hospital that the risk factors were identified for this family as high risk, or through family health practice, or through our staff who are dealing with different families throughout the scope of our services. And when that referral happens, one of our nurses will visit with the family and guide them through ensuring risk factors are identified and the family is supported through the period of time that we follow up with them, and we connect them with other partners, whether it's services, municipal services, or healthcare services. So that's where I believe we do the bulk of our response to prevent and provide better health in the long term. Can we do more? Definitely we can do more. I believe in public health early on, it was every family, every newborn is assessed. Now it's only high risk families. So again, the system might not be perfect. Can we do something locally to ensure more resources are available after identification? Definitely we could. Again, that's one part of the equation around that early childhood development. There is a part where before birth happens, if the family, if the mother has sufficient resources to have healthy pregnancy, that definitely contribute to better outcome after the fact. So we can go upstream, and that's the better approach. I don't know if that answers the question, Warden.
I think that's very helpful, but it sounds like we, as Allison says, we probably need to do justice to this whole area and have a wholesome discussion.
Most definitely. And if I may ask, Mr. Chair, if we can get more precise parameters around the presentation that the group would like us, public health, to present on, whether it's the statistics or the epidemiology in Grey Bruce, or a bit more fulsome plan from public health.
I feel like there's so much to talk about and so many topics, and I learned a lot today myself, but I'm sure there'll be lots for the next meeting. Okay, go ahead, Phil.
No, I just want to apologize. I do need to step off and join Clark in the Ontario Health Team Grey Bruce meeting. Yeah, but I would say that if we're looking at our next meeting in March to have a more fulsome discussion, diving a little deeper in with Naomi and Clark and myself and Dr. R and others, if something is brought up in the next few minutes of your meeting, please, I'm hoping Tara, maybe you could forward me the directives in terms of what you're hoping us to speak to in more detail in the next meeting in March. I'll just, there is a bit of a conflict at 4 o'clock every other Tuesday. So working from this timeline, we do have the Ontario Health Team meetings that are written in stone. And you all have heard Clark speak. He's not a man that you can make him move things. So he's the chair. So he's not going to move those meetings. No, I'm kidding. I'm sure he would try to do that if he could. But it's a large group of CEOs and executive directors in the health system that are tied to those meetings. So again, I'll apologize and I'll take my leave as I should jump into that meeting, and looking forward to coming back together in March and joining the conversation.
Okay, thanks very much, Phil, for your input. Appreciate it.
Thank you.
Okay, I think we can get to the motion, Madam Clerk.
If I may, Mr. Chair, just to provide a wrap up and sort of direction, I take the comments from the task force into consideration. We have a number of stakeholders that staff had come together on, but certainly that's not an exhaustive list. And so we will be working through the list of stakeholders as staff over the next several months. And if there are any that come to mind that are missed in this, like the school boards was an excellent idea, please feel free to let staff know. We want this task force to hear from as many stakeholders as possible to bring forward that business case, to look at those opportunities and provide that fulsome report at the end. So we as staff will be reaching out to the stakeholder to provide a bit of background as to what the parameters are we're looking for presentations. But if there's somebody missing from that list, please let us know, and we will work with them to ensure that the task force hears from them.
Okay, thanks for that, Heather. So I think we've had a thorough discussion on that. We'll move on to the motion moved by Councillor Klumpus, seconded by Councillor Carlton, I believe. If I remember, that was a long time ago.
That is correct.
We'll call the question. All in favor? Okay, and that is carried. Any other business on number 6? Seeing none, the next meeting date, we don't know then at this point?
No, but we will work around the OHT schedule since that's a conflict for Mr. McFarland and Mr. Dodd, and we'll come together again at the end of March.
Okay. And on to number 8, we need a mover to adjourn. Councillor Burley. Of course, it's Councillor Burley. Seconded by Councillor Carlton. That'd be great. All in favor? And that's carried. Thanks very much, everyone. Take care.